The first paper, there is no change. It's given by Dr. Tessa Cook from the Hospital of the University of Pennsylvania. And as I recall, Dr. Cook was one of our travel recipient winners last year, so it's really excellent to see the money that we've invested in young investigators coming back and helping us out. Dr. Cook will be speaking on development of an automated follow-up tracking and feedback system for radiology, clinical, and laboratory studies. Dr. Cook.
Thank you, Dr. Weiss, and good afternoon, everyone. I'll be sharing some of our initial experiences in developing a tracking system for follow-up recommendations in radiology reports. These are the author's disclosures. So why is follow-up tracking important? Well, take this example. A patient comes in for a routine chest radiograph, and the radiologist that interprets the study identifies a left upper lobe lung nodule. He makes the report, recommends a chest CT, and makes a note to himself to follow up when the patient actually obtains that secondary study. Some time goes by. The patient does return for that follow-up examination, and now a second radiologist interprets the exam, compares to the original radiograph that initiated the follow-up examination, and reads that there is a left upper lobe mass suspicious for lung cancer. Now, at least at our institution, no correspondence is then sent to the original radiologist who interpreted the chest x-ray to inform him that the follow-up study has been obtained and what the results of that study were. As we know, that radiologist made a note for himself or herself to follow up on that particular patient, but who knows where the post-it note is at this point. So in order to actually get this information, this radiologist would have to search through at least one electronic medical record, possibly more than one, to find the results of the follow-up examination. So the potential impact of follow-up imaging is certainly multifactorial. For the patient, it can mean increased expense, possibly increased exposure to radiation or contrast agents, depending on the modality of choice for the follow-up study. For an imaging center, this can relate to issues about utilization, possibly to self-referral. And for the healthcare system as a whole, this is potentially increased cost and demand. And as we know in the current environment with the recent healthcare legislation that's passed, these are all issues that are on everyone's minds. And so to address this potential problem, we set out to develop a follow-up query and then also to develop a tracking system for follow-up recommendations. And so the first step was the development of the query itself. And in order to do this, we surveyed 12 subspecialty attending radiologists at our institution, and we asked each one of them to provide us at least 3 phrases that they used in providing follow-up recommendations in their reports. And so we took this collection of phrases, we identified 55 phrases in total, pared that down to 46 unique phrases, and then also did a review of some of the radiology reports for some of the sections that had not been represented in the survey to identify additional modality-specific or specialty-specific trends in follow-up recommendation. For example, in our women's imaging section, they have a very specific set of macros that they use when they recommend follow-up studies. So we combined all of these phrases and implemented this query within Presto, which you may have heard about this morning during the learning session for this track. Presto is the Pathology and Radiology Enterprise Search Tool, which was developed by Dr. Woojin Kim at the Hospital of the University of Pennsylvania. And so the follow-up query is implemented within Presto using PHP and MySQL with an interface to the Microsoft SQL Risk database that we have. So in order to validate the query, we looked at over 2,500 reports. We chose a random day in 2008 and looked at all of the reports that were finalized on that day. We classified each report manually into whether it recommended follow-up or did not. And the classification was done in a blinded format. In other words, the phrases that constituted the follow-up query were not available for reference at the time that the reports were classified. And so we then applied the follow-up query to this same set of reports and achieved a 95% sensitivity and a 96% specificity for detection of follow-up recommendations. So that was the first step, actually figuring out what follow-up, what studies recommend follow-up. The second step then was to actually start to track this data. And so the system consists of 2 databases. The first is the tracking database. And the idea is that the follow-up query is applied to each day's reports to identify any reports that contain a follow-up recommendation. And information about those particular studies is then stored in the tracking database. Then each day, as new reports are generated, we search to see whether any of those follow-up recommendations was actually obtained. So that's where the potential match database comes in. And so now we actually search each set of studies generated on the previous day against studies that have been flagged in the tracking database. Any potential matches are stored in the match database and then ranked for the strength of their correlation to the original follow-up recommendation. And so these are the criteria that are used to actually rank the follow-up matches. If the modality matches, positive points are awarded. If the exam code is the same as the exam code of the original study, points are awarded. If the ordering physicians match, in other words, the physician who ordered the initial study that prompted the follow-up recommendation presumably read the report, saw the follow-up recommendation, and then ordered the subsequent study. So that's considered a positive match as well. Recommendation phrases such as clinical correlation or reports where tissue sampling, such as pathology, correlation, biopsy follow-up was recommended, these are assigned negative point values with the idea that if lab or pathology recommendations were provided, an imaging study is not really satisfying that as a follow-up criterion. So in the initial implementation, matching studies were any studies that accumulated at least 10 points. And so this is an example of the interface. What you have here on the left is the original report, which contained the follow-up recommendation, and this is highlighted here in yellow. In this particular instance, the initial study was a mammography examination, and breast MRI was recommended. The system will attempt using proximity searching to extract information about the modality, so in this case MRI, which is suggested for the follow-up study, and any possible follow-up interval. And in this particular case, you can see there's no follow-up interval is recommended. The terms highlighted in green on both sides represent the RADLEX terms within each of the reports. And the report on the right is the follow-up examination, the matching follow-up examination to the original report. And so in this case, again, we extract the modality, because this is now an MRI that the patient obtained, and just identify the interval since the prior study, which in this case was fairly short, 8 days. So in our initial experiences with this system, we realized that we needed to incorporate additional criteria and additional constraints for what constituted a matching report, a matching follow-up a report that matched a prior follow-up recommendation. We found that we were getting too many matches. And so these are some of the criteria that we're currently implementing to upgrade the system. One is to look at correspondence between RADLEX terms. And understandably, in radiology reports, if you're talking about the same body part, you're probably going to have a fairly high correspondence, but we want to look for correspondence frequencies or degrees that are significantly higher than sort of the background. The other thing that we want to include in the criteria is the strength of the initial follow-up recommendation. So there's a clear difference between the phrase comparison with cross-sectional imaging is recommended, where there's clearly a recommendation of please go and obtain cross-sectional imaging in this particular patient, versus a phrase such as comparison to prior, which could mean I'm comparing the current study that I'm reading to a prior that exists, or I'm telling you to go and compare this prior study to a prior report. So incorporating this into the follow-up metric is also going to help us to increase the strength of these correlations. The anatomy, the specific anatomic part being imaged, not just the exam code itself, is also going to become a part of the ranking criteria, because you can imagine that a CT abdomen and pelvis without contrast doesn't have the same exam code as a CT abdomen and pelvis with contrast, and so those would not reflect correspondence necessarily in the original scheme. And in addition, we are considering including some adherence to the recommended follow-up interval. And for example, if a patient comes in and gets a chest CT with a lung nodule and follow-up is recommended in 6 months, a study that actually falls within that 6-month window might earn a few extra points than a study that falls outside that window. So these are some of the things that we're considering at this point to help to refine the ranking criteria. So this is part of a lot of ongoing and future work on this project. In addition to the optimization and validation of the algorithm, we are going to start retrospectively, or I guess continue to retrospectively populate the tracking database so that we can identify studies that are follow-up examinations that come down the pike in the future, and also to focus on quality assurance and business intelligence measures, looking at how often studies are obtained within the recommended follow-up interval. For example, when exams are overdue, is there a reason we can identify for why the patient doesn't get the follow-up? Is it that they're not getting imaged in our system? Is there something else going on clinically? Did the referring physician choose a different modality, et cetera? And we can also use a lot of the information that we get from this system to provide feedback not only to the radiologists in the department, to the ordering physicians, and perhaps even to the patients themselves. And so what I anticipate in the near future is, for one, being able to close this loop. Now, when the patient comes in to get the follow-up examination, though it may be interpreted by a different radiologist than interpreted the original chest radiograph, this block of information no longer exists, so that the first radiologist also gets notification that this follow-up study that you were interested in was obtained, and these were the results. And almost more importantly, in cases where patients don't receive the recommended follow-up, to try to identify potential reasons why that might be happening, to do some sort of analytics to determine if we can change processes within the department that can facilitate patients getting follow-up, or just to identify reasons why that follow-up is not obtained. Also, to create alerts for the radiologists that originally recommended the follow-up examinations, as and when patients exceed the recommended time interval, to say, remember the CT you read, the patient never got follow-up, perhaps it might be something to look into. And to also encourage communication with referring physicians as well as patients regarding follow-up examinations. So I thank you for your attention, and I'm happy to take questions.
I know that there's a federally required mandate for radiologists to follow up things like mammography. Mm-hmm. What do you think is the radiologist's responsibility to follow up an imaging test that they made a recommendation on that maybe hasn't been followed up?
I think it really depends on the study itself, and I think in cases where there's some acuity related to the finding that follow-up was recommended for, then we certainly have a responsibility. A lot of times I note, and someone actually said this to me in the reading room, which I thought was a little strange, is I don't expect them to follow my follow-up recommendations. And I wasn't quite sure how to interpret that, because if it's not something that you feel that there's acuity associated with, why make the recommendation? So I think it really varies with the particular finding and the particular exam and sort of the overall situation for the patient.
I have a question by text, if I can get it back up. How did you decide on the number of points to assign for each match, and how sensitive is the result to this weighting? Very good question.
Very good question. I agree. So this was really sort of a pilot project from our perspective, and we've tried to assign weights to things that we thought would be more important with respect to finding these correspondences. What we're actually looking at now is doing a statistical regression to see if we can pull out the parameters of interest from the reports that we currently have, and then actually do some sort of ROC type analysis to see where we can set our thresholds so that we can actually refine the ranking process, because I think that's the really significant part of this work, is finding a ranking process that works effectively.